Welcome to today's episode of podcast brought to you by ISCCM. We have the honor of speaking with Dr. Marlies Ostermann, a renowned nephrologist and intensivist based at Guy's and St. Thomas Hospital, NHS Foundation Trust in London. With an impressive background in acute kidney injury, renal replacement therapy, and critical care, Dr. Ostermann has made significant contributions in the field through her clinical work and research. Her expertise in the management of complex renal conditions, particularly in critically ill patients, has made her a leading voice in nephrology and critical care communities worldwide. We are thrilled to have her here today to share her insights and expertise. We welcome you, ma'am.
Thank you very much for the very kind introduction. I'm truly very honored to join this meeting. And I would like to start by thanking you, the Indian Society of Critical Care Medicine, and all your colleagues for the wonderful hospitality I've experienced in the last few years. And I've learned a lot at meetings in India and from discussions with colleagues. So I'd really like to express my sincere thanks to you and your colleagues.
Thank you, ma'am. It's an honor. So I'll start with the first question, ma'am. How far are we from diagnosis of acute kidney injury based on structural markers rather than functional markers? What are the current challenges we are facing in implementing these new biomarkers in clinical practice?
That's a really important question. So at the moment, the definition of acute kidney injury is based on urine output and creatinine, so functional biomarkers. And this is according to the consensus criteria as agreed by the KDIGO expert team in 2012. But clearly we have new markers. We have the structural markers, or sometimes called damage markers. And they've given us so much more insight into the pathogenesis, but also have told us that acute kidney injury occurs much earlier before the creatinine goes up. So these new structural or damage markers have truly advanced our field in acute kidney injury and given us opportunities to intervene early. Hence the call to integrate them into the current definition. So at the moment, the KDIGO definition or KDIGO criteria for AKI are the accepted criteria for acute kidney injury. But the Acute committee, expert committee, and experts around the world, and a lot of people also from India, have called for a revision to really with the intention to diagnose acute kidney injury earlier and to manage acute kidney injury earlier and prevent progression. So the KDIGO executive committee has taken this on board, and they have convened a new committee. And this committee is looking at a revision of the KDIGO AKI guideline, but in particular the definition. So hopefully by next year, we will know whether the official guideline, the official definition of acute kidney injury includes structural biomarkers as proposed by a lot of experts and the Acute committee.
Thank you, ma'am. Thank you for giving us clarity on the structural biomarkers.
I think you asked me about challenges as well. And I think the challenges are very clear. The problem now is that these biomarkers are so much more expensive. They are expensive for anybody across the world. And in my own practice here, I cannot afford to use them routinely in clinical practice. But in contrast to urine and creatinine, which are are affordable across the world. So we need to find a way of making them affordable to everybody across the world if we want to make use of them. And that's the big challenge.
I agree with you. I think the cost factor is actually the main thing, which is being an hindrance at putting it in regular clinical practice. Thank you so much.